To do the walk of shame.
No.
Dr. Syed, I'll tell you what, man, you're almost too late. So, are we good to go? Okay. All right, guys. Well, yeah, I'm going to do something a little bit different today. I was asked exactly 10 days ago to give a lecture for you guys, and I said, well, what topics would they like to discuss? They said, well, whatever you have prepped. I said, well, that's several things, but have they done a COPD update yet this year? And basically what I heard was no. The reason why I asked if you've had a COPD update this year is that in 2007, there was a significant change in the GOLD guidelines, enough that it's worthwhile to review that, both from an inpatient and from an outpatient standpoint. Now, we're not going to get into treatment specifically from an inpatient standpoint. Most of it we're going to talk about is more of the diagnosis and what exactly changed with the GOLD guidelines in the course of this year. But before we do that, I really want to kind of go back and do a quick review. I think for you guys here, for the students especially, and for anybody who's watching, it's good to have a review of COPD and just a reminder of how we make that diagnosis, what do we come up with, and then, you know, what are some of the definitions that we kind of throw around. All right? So let's start out with this. What is COPD? What does COPD stand for? Chronic obstructive pulmonary disease. Okay, now in medicine, I think names need to tell you a little bit about the disease process, but also need to give you a help in how we diagnose, okay? So chronic obstructive pulmonary disease is a perfect example of a disease process whose name basically tells you exactly what's going on. So what does chronic mean? What does chronic mean? Longer than 6 months, okay? You say 3, longer than 3 months, longer than 6 months. Is it possible to have a chronic disease and have it less than 3 months and 6 months?
Yes.
Okay. Technically. Okay. Give me an example. Give me an example.
If it's like you can't reverse it, right?
Right. So there's more to it than just time, right?
You can't reverse it.
There's other things. So the idea that you can't reverse it, that it's something that doesn't necessarily get better with time, but actually has a progression to it that requires medication changes over time in a combined source. So let's say you have a person who comes into the emergency room and they have a blood sugar of around 400 and they're in metabolic acidosis, and you diagnose them with DKA. You diagnose them with DKA today. They never knew they were diabetic prior to this, but do they have a chronic condition? Yeah. They haven't had it for 3 months, they haven't had it for 6 months, but do they have a chronic condition? They sure do. And they're going to have to be monitored for that over time. Now, a chronic condition implies one of two things. Either one, that there is a disruption of the normal activity of an organ or a body system, or you have destruction of that same organ or body system, okay? So either altering in function or you have actually destruction and loss of that. That's what defines a chronic condition. It's not something that gets better. It is something that is because of an irreversible change. More often than not, chronic disease management requires frequent follow-ups and changes in medication over time. Very rarely do you put these people on a set of medications and leave them on them for 50 or 60 years. They're going to require frequent visits. They're going to require regular checks. Now, what does obstructive mean? You know this.
Air trapping.
Air trapping. Okay. What does air trapping mean? What does that mean? Anybody?
You can't exhale all the air they have in their lungs.
Okay, they can't exhale, they can't get out the air that's in their lungs. Okay. Why is it, what's the opposite of obstruction? Where you can't, so you can't get air out, what's where you can't get air in? Restrictive, okay? So I'm not trying to get it, I'm not trying to do something really fancy here, guys. just understanding that obstruction simply means that you cannot get air out. Now, there's different mechanisms by which that happens. The most common one being, something we think of like air trapping, like Bernoulli's effect on the airways, increasing air flow causes decrease in pressure within the alveoli, and in the bronchioles, those cause constriction and collapse. And really what we see with COPD is we see destruction that's contributing to that, right? The architecture of the lung itself is breaking down. The elastic bonds that keep those airways open when that pressure changes are gone, and as such, we see those airways collapsing. That's the physiology. That's actually what's going on with a lot of these patients. Now, pulmonary just means lung, right? And disease means there's something wrong with it. So we have something wrong in the lung where they can't get air out, but it's not going to get any better, right? That's what COPD is. It's important to remember that because that helps us to define, helps you to understand when you're trying to make this diagnosis and trying to figure out severity, what exactly is going on. Now, what kinds of COPD are there? Oh, okay, emphysema. Chronic bronchitis. Asthma.
And the overlap.
And the overlap. There's another one, small airway disease. Okay, now here's the thing. Technically, asthma is not a form of COPD, okay, because it is a chronic condition, or it has an acute component to it, so it's not technically COPD, right? So asthma doesn't technically fall into that. But the three we hear all the time are emphysema, chronic bronchitis, and small airway disease. This hasn't changed. These terminologies are still used, not infrequently. The thing is, they're becoming antiquated. We're not talking about COPD in terms of emphysema and chronic bronchitis as much anymore. We do consider them, especially when we're talking about different types of therapies, but really what has changed with the advent of things like the GOLD guidelines and the ATS guidelines is to try to standardize what COPD is. These terms have been around for a long, long time. In general, emphysema points to destruction of those elastic bonds that maintain the airway's patency, right? And when you get that, you get these areas where air comes in, it gets trapped, you get these bulla formation. That's essentially what we're dealing with in emphysema. In chronic bronchitis, we see hyperplasia of the goblet cells. We see increased production of sputum. And we find that these are areas that become, because they don't get mobilization, they become highly proteinuria areas. They become areas that are very susceptible to infection. And as a result of that, they tend to have more and more exacerbations and more bacterial type of infections. Now, in addition to those, there's this other one that's kind of, it's not really well defined. But small airway disease has really been discussed since about 2004 as being a significant diagnostic tool. And actually, it's been more utilized or more useful in asthma in younger individuals than it has been in COPD patients. But ever since about 2007, we've been talking about it with COPD as an early marker that this person is developing changes in their lungs that won't be reversible. Okay. Small airway is looking at that F2575 on your pulmonary function test. We'll talk a little bit more about that here in just a second. Okay. Now, what I'm getting at is this is where we've come from. This is what it has been. And yes, there's overlap. As a matter of fact, the reality is that overlap is probably the real problem. It's all of these things combined, right? And so before we actually had clear definitions as to what COPD was, we had a bunch of different groups trying to describe it. We had the European Respiratory Society, we had the American Thoracic Society, the American College of Physicians, the American Chest Physicians. All of them had their own kind of way of describing what COPD was. Of course, prior to about 10 years ago, COPD wasn't really on the radar because 10 years ago, COPD was not even on the top 10 causes of death in the United States. Where is it now? All right. Who likes less than or 5 or higher? Likes, okay, so it's, yeah. Okay, who likes top 2? Who likes top 3? Who likes top 4? Okay, so right now, COPD is still number 4, but it's rapidly approaching diabetes to take over as number 3. As far as I know, it hasn't changed yet, right? So right now, it's still 4, but think about that. 10 years' time, it wasn't even in the top 10 or top 10. Now it is number 4. And if you were to look at progression of disease, you will see that heart disease has gone down. Not a lot, but it has gone down. You'll find that cancer has actually gone down more. So you will find that diabetes is pretty level. But COPD isn't just rising, it is flying up in numbers. A lot of that has to do with the risks and exposures that we're having, the fact that we're living longer, because it's normal for us to lose some level of lung function as we get older. Okay, and so now these people are living long enough that they're actually seeing complications of the disease. All right. So, all right. Now that they have, when they came together and they said, all right, we need to have a more stringent guideline. That was 2010. They had an update in 2014. They've had another update in 2007. So let's talk about a pulmonary function test, and then we'll start talking about how we actually name COPD and what that means from a treatment standpoint. You guys all remember flow volume loops, right? Wait, I did that wrong. All right, who wants to do a normal flow volume loop for me? I'm going to call on someone. All right, come on up, Dr. Ingman. Woo-hoo. Give me a rough estimate, huh? It's not great. All right. Okay, I like that you put in your own x-axis. Because technically, I put in an x-axis, and I was like, well, good heavens, that's... I was like, how to fill up the box? Okay, can't think outside the box. All right, well, I didn't exactly put, parameters, so I get that. All right, what do you think? Anybody think they can do better? Probably not. All right. I'm going to erase this only because I want it to fit on my thing, but I will try to match it as best as you got, all right? I love it. All right, so coming up, coming down and around, kind of like that, right? Oh, it's like, well done, well done. Okay. Anybody like that one to think that's a really good flow volume? Anybody think they could do a little bit better? Okay, so let's say this is a good one. Can somebody come up now and show me what a obstructed flow volume loop is? Ozzy, you really look like you want to come up here. Go for it. Come on, buddy. Really don't. All right, come on. Best of your ability. That's all I'm asking. That's right. I'm just going to tell you all you're wrong anyway, so go ahead. No, you'll do fine.
Cleveland, please dial 1750. Cleveland, please dial 1750.
How do I? All right. Just draw it. It's all right. Yeah, just draw over it. That's why they're different colors. All right, well, that's a good start. All right. Worse. Okay. Well done. All right, who wants to do restrictive? Dr. Gatewood, I know you're all over this one, buddy. Restrictive? right. So we got 3 different flow volume loops. They're a little bit off from each other. Let's talk about it. When you think about the name of COPD, okay? A normal, you start at 0 and you come up. So your volume goes up when you inhale, okay? Now, when you breathe out, in a normal person, do you breathe out quickly or do you breathe out slowly? Relatively quickly. But it can go on for a while, okay? Initial flow is going to be relatively rapid, and so you can actually see a drop that's relatively quick initially, okay? That then gets carried out over time to the point where it then comes back around. So that would be a normal flow volume loop when we're talking about somebody who does not have COPD. The problem with COPD is that it creates a system where even though they can get the normal amount of air in, that first exhalation is substantially delayed. So now we actually have something that's dragging out over a long period of time. And in fact, it can go on for quite a while, okay? So instead of having a nice quick drop, we're actually seeing this ongoing for a while. And again, we'll come back over to the same ruffle area because inhalation is not a problem. Now, if we're dealing with a restrictive process, breathing in, they never actually quite get up to where that total lung capacity is, right? Because they have a blockage. Now, is their problem getting air in or getting air out? Getting air in. So the problem is that they have a lot of restriction with that. So how fast is the air going to come out? Pretty fast. Because you're actually almost getting force. You're almost going against a restriction on the chest. And that's going to come out, and then you're going to have a really shallow inhalation period. So the 3 different volume loops that we see are roughly in this particular pattern. Now, the reason why that becomes important is when we start looking at numbers. Okay? We don't necessarily make decisions. We don't make the diagnosis of COPD based purely upon what that volume loop looks like. However, this volume loop can give you a lot of information as to the quality of the study that you're dealing with, and also, in general, what might be the pathology that's there. Unless you see multiple different flow volume loops, you're going to struggle. Okay, so keep that in mind. Now, when you're looking at a pulmonary function test, what is the first thing you should look at on a pulmonary function test?
Patient's name.
Patient's name. Patient's date of birth. Check, check, check. Okay, we have identified that this is the correct patient for this procedure. Let's say that we're doing we're reading the pulmonary function test. What's the first thing you should look at on a pulmonary function test? The interpretation? Nah, come on. What should we look at first, Garrett? What do you think? Any ideas? Anybody? Okay, so I have several here. I've got FEV1. Ooh, that's not yours. FEV1. I've got FEV1 to FVC ratio. Which one? Who likes FEV1? Who likes the FEV1 to FVC ratio? Who doesn't want to vote? Lots of you. Come on, guys. Come on. Get active here. It'll be way more fun. This is the first thing we want to look at. Why do we want to look at that?
This is more information.
Oh yeah? What information does it give you, Dr. Gaywood?
FEV1 and FVC.
Well, okay. Nice.
It gives you the amount, the ratio, amount of time compared to your capacity
What is FEV1?
over 1 second.
What over 1 second?
4 seconds.
How much air you got out in 1 second? Okay? Remember, what is obstruction? You can't get air out. So forced expiratory volume 1 second. How much air did you get out in 1 second? All right? What's forced vital capacity?
How much air you typically breathe in or out? without looking at the reserve.
Okay, how much air you take in? How much air, how much of what you took in did you get out in 1 second? Okay, that's what that ratio tells you. How much of what you took in did you get out in 1 second? Or how much did you breathe out in 1 second? Now, what's the magic ratio here that we want to remember?
What-
All right, see 0.8. I hear 70.
5.3 as well.
I hear 0.5 and I hear 0.3. Okay. A, B, C, and D. Who likes A?
I mean,
Okay.
what do you, I don't know, what are you asking metrics for what?
FEV1 to FEC ratio, if we're looking for obstruction.
Oh, so like what is considered significant obstruction?
No. What number am I looking for? All this tells you, what does this tell you? How much air you got out in 1 second. Does that tell you severity? No. It just tells you, do you have any level of obstruction? Don't get confused. There's other factors that we look at, but the FEV1 to FEC ratio does not give severity. That just tells you how much air you took in, how much of it you got out in 1 second. So, which one of these numbers is the one you really need to know? Who likes A? Who likes B? Who likes C? Who likes D? Dr. Grider raised his hand for this one. Now, technically, 70 is not a ratio. I'm just going to throw that out there. 70%. Yeah, okay, yeah, 70% or 0.70. Okay, if you have lower than 0.70, you are, by definition, what? Obstructive. Does that tell you anything about severity? No, I just said that, right?
There's actually an interesting counterpoint in American Journal of Respiratory Critical Care on this topic a couple of months ago, arguing that if you just use the FEV1 to FEC ratio as your screen for obstruction, you're going to end up missing a bunch of people because of the possibility to have comorbid restrictive and obstructive disease. Actually, the first thing I look at is the flow volume loop to say whether there's one or the other or both. Is the peak displaced laterally? Maybe we have a restrictive disease. Is the expiratory limb scooped out because of elastic recoil and obstruction? And maybe we got both. So it tells you about the reproducibility of the test and the validity of the test. It tells you what you should be looking for, and then you can use the numbers to back up that argument or not.
Yeah, and actually, utilization of the FEV1 to FEC ratio as your only method for determining if they have obstruction is definitely something that has to be this. That's more of a mixed picture. I think for the purposes of you guys, and then also from a standpoint of boards, and when you're looking at studying, the number you need to know is 0.70. Okay, and here's the thing: is it less than or equal to, or less than? If they're 0.7, do they have obstruction? Who likes yes? Who likes no? According to GOLD guidelines, it has to be less than 0.7. Now that's according to GOLD. If you look at ATS, it's actually different. So there's actually a little bit of variation there. And then when you start talking about some of the critical care stuff that's out there too, again, there's some variation. I'm talking predominantly about GOLD right now, though. Okay. Now, after you've looked at the FEV1 to FEC ratio and you have determined that this person does in fact have obstruction, what do you look at to determine the severity of that obstruction? FEV1, anybody else? What else? Anything else? Okay.
And the post-bronchodilator.
Okay. Pros, bronchodilator FEV1.
That is all.
I was going to get to that.
But also the FEF 2575.
Absolutely. Okay. When we're looking at severity, it's a combination of different things put together. Now, the first level, what I would expect medical students to know, okay? is FEV1. Do you want to look at your FEV1? And the reason you want to look at your FEV1 is because what's the problem? What is the O in COPD? Obstruction. Obstruction means you can't get air out. So we want to know how much air can you get out. That determines how severe that COPD is, right? Okay. Now, there's different numbers and there's different values. We'll talk about the gold stages here in just a second. Post-bronchodilator. Why would post-bronchodilator FEV1 be even more important than just the FEV1? It takes away the part that is reversible. Remember what the name is? Chronic. What does chronic mean? Irreversible change, right? So we want to know, it's in the name, what is an irreversible change with COPD? So post-bronchodilator takes out the part that's reversible. And that really gives us the best indicator of severity of that COPD. Okay? So these are different levels of knowledge. FEV1 is the one you need to know. Post-bronchodilator takes out the part that's reversible. And then the FEF 25 and 75, after you kind of got this standardized, what you end up doing is you look at both of them, and we're trying to find out, we're going to blend that. Because sometimes you can have relatively mild disease here, very severe disease here, and we end up calling them moderate or severe, depending upon how those numbers work out. Now, I'm not going to give you a lot of numbers, but I want you guys to understand, the first thing you look at is the FEV1 to FVC ratio. If it is less than 0.7, that person is obstructive. The next question that's going to be asked is how bad is that obstruction? And so we're going to look at the FEV1. If we're looking at the FEV1, what are the numbers? We've got gold, 1, 2, 3, 4. Those used to be called, FYI, used to be called mild, moderate, severe, and very severe, AKA lung transplant. Or dead, I guess, if you want to do that. No, I'm just kidding. They're very severe. Okay. Mild, moderate, severe, very severe. Number one, this changed with GOLD guidelines in 2014. What changed in 2014? Or why did they change that? Do you guys know? It changed the way that they treated? Not necessarily.
ABCD or something like that.
Oh, that's different. We're going to get to that in just a second. That's a category. We'll talk about that. But why did they stop calling it mild, moderate, severe, and very severe? Who cares what mild, moderate, severe, and very severe are? I'll tell you, there's only one person who does. The patient. Right? So you tell a person that you have COPD. They're like, oh, how bad's my COPD? Well, it's mild. Okay. It's only mild. It's moderate. Well, that doesn't mean anything. Right? The idea was we wanted to get away from this concept that that COPD mild isn't that bad. COPD is bad. Understand that if people are symptomatic and they're coming to see you because of COPD, that means they've had disease for quite a while. If we look at lung function versus symptoms, scared someone away. Yeah, okay. Or not symptoms, I'm sorry. This is function, this is time. I'm getting everything back. Let's say you start out at 100%. Over time, that starts to drift down, right? And it's normal to lose lung function over time. Let's say this is birth. Let's say this is 100 years. Okay? It is normal. This line right here, this is symptom. So in a normal person who's losing lung function over time, they never actually reach a point where they develop symptoms. Now what happens if that person decides to smoke? The decrease, it goes down a lot faster. Okay? Now we'll take one of two scenarios. Let's say this person has smoked for 20 years. Okay? You'll notice not everybody who smokes 20 years is going to have symptoms. But at this point, one of two things can happen. Let's say this person decides to quit smoking. All right? They decide that they're going to quit. They're not going to have any problem, or they're not going to smoke anymore. Does their lung function come back up here?
No.
No. What happens? It'll actually follow the same rate as the other one, and it goes in parallel. Now, it falls at a substantially less rate than what they were on before, and it is possible that they will get to the end of their life without disease. Now, if I were to ask you what percentage of people who smoke will develop COPD, what percentage is it? Okay, I've got 80, I've got 60. No. They have people who smoke that will develop COPD. I've got 80, I've got 60. Who else likes other ones?
18.
18. Okay. Anybody else? More than $1, right? Sam, what do you think? 20%. Okay. Who likes 80? Who likes 60? Who likes 50? Who likes 40? Who likes 30? Who likes 20? Okay, who likes 18?
Thanks.
Okay. 5 years ago, it was 18. It's actually about 21 to 22% now. It's right around 20%. Okay, so 20% of people who have ever smoked will develop COPD. Now, that being said, what percentage of people with COPD have smoked?
90-something.
It's about 95%. Okay, so yes, smoking is a major factor, but it's because of this. If they can quit, and if most smokers can quit prior to the age of 45, the risk of them having substantial symptoms in their course of life is much less. So we use this from an education tool every day with our patients in the office. Look, you're 45 years old. Today is the magic day. You can quit and have no long-term complications. Okay? That's better than saying you're going to die. No, this is your chance. Every day after that, we get a little bit more problematic. And that's purely a statistical thing. There's people like George Burns who lived to be 100, who smoked 2 cigars every morning and drank 2 martinis before breakfast. Okay, he's a pickle. He's not going to go anywhere. Now, the other thing that could happen here is, let's say this person decides to continue to smoke. At that rate of decline, they are going to reach a point where they start to develop symptoms. And actually, it's symptoms that end up bringing a person in, right? How do we clinically define, or how do we clinically diagnose a person with COPD? You have to get a PFT. Now, let's say you came into my office and said, Dr. Hardee, I want to have a PFT done because I think I might have COPD. What is going to be my next question for you? What symptoms are you having? Why would I ask that?
Because you're wondering why they think they have COPD.
Why on earth do you think you have COPD, right? So in order to order a pulmonary function test, okay, first off, let me ask it this way. Is there any indication for a screening PFT? Under what circumstance, Dr. Grader?
There's several. So chemotherapy with bleomycin or stuff that's known to cause restrictive lung disease, there's an indication for screening there. For ATS guidelines, if you have a lifetime total smoke exposure of greater than 20 cigarettes, which is pretty much everybody that smoked ever, there's an indication for screening PFT there. And then U.S. Preventive Services Task Force, I don't think they have a current recommendation, but they used to, along the guidelines of ATS, and said just lifetime smoking exposure was X, you should do it, but I don't think that's current.
So the U.S. Preventative Task Force has said that they would consider doing pulmonary function testing of anybody who is at risk behavior. Okay, but the 20 cigarettes is an ATS only. GOLD does not recognize that. So GOLD does not recognize exposure to cigarettes alone as an indication for a screening pulmonary function test. The only one that I am aware of that GOLD actually recognizes is medications that may induce either restrictive patterns, not necessarily obstructive, but restrictive patterns because of treatment, so chemotherapies and things along those lines. So that is the only indication I can think of for screening. For the day-to-day person, there really is not a significant indication for screening pulmonary function test. So in order for if you're in the outpatient world and you want to get a pulmonary function test ordered and you want insurance to cover it, you have to show two things. What do you have to show? Symptoms and exposure. Not necessarily just tobacco, they just have to have exposure. Now, how hard is it to show symptoms and exposure? It's not that hard. If you want to get a pulmonary function test, but you have to document that. For you guys who are doing clinical stuff, you have to document that in order to get that test justified by insurance. Now, what symptoms are we concerned about?
Getting short of breath, walking 100 meters.
Okay, shortness of breath with exertion, specifically with 100 meters, okay? Does it have to be 100 meters?
No.
Could it be
With
400
strenuous
meters?
exercise, with extreme exercise, it's 100 meters, then there's like putting on your clothes.
Okay, so you're talking about actually like, yeah, what kind of level of activity are you actually able to do? Okay.
Less than their baseline.
If they're less than their baseline, you can justify it. So if you have shortness of breath with exertion or just change in functionality in a person, that's actually a symptom. What else? I heard shortness of breath, fine. What else? Cough, increase in cough. What else? Sputum production. So we're looking for shortness of breath with exertion, sputum, and cough. Which is the most common one to actually bring people into the office? Cough. What's the most common to show up first? Shortness of breath with exertion. So decreased exercise capacity. Okay? So it behooves us also to be asking people about that. Have you noticed your exercise tolerability, especially if they're a smoker or if they've had significant exposure? Good question.
I find most of my patients chalk the latter one, the decreased exercise capacity up. I'm just out of shape.
I'm out of shape or I'm getting older.
I'm getting
You know, I'm
older.
getting older, I'm
Out of
not
shape.
saying. Because we're internal medicine, most of our patients are getting older.
They don't complain about it, because they're like, well, I'm just out of shape. I'm like, are you sure you're just out of shape?
So you have to have both of those in order to order a pulmonary function test. Now, here's the thing. If they're there to get the pulmonary function test, where are they at here? Okay? Either something else is causing them to be in a decreased function, or they're down to where they have symptoms. Now, this is where this becomes interesting, is when we talk about mild, moderate, severe, very severe. Mild disease, by the time they get to you, if they have it, they're still here, okay? Their overall function is probably down. Now, the natural course of COPD, if we look at this being time and this being symptoms, what you actually get is, you know, they have more symptoms, and then they have less symptoms, and then they have more symptoms, and then they have less symptoms, and then they start having more frequent symptoms, right, as they go on with time. So they have good days, they have bad days. These are the days that they're not needing you. These are the days they definitely need you. Mild, moderate, severe, very severe for the patient meant something. For us, it didn't, because they have COPD and they need to be treated. So they changed it 1, 2, 3, and 4. What are the numbers here? What's 1? Greater than 0.8. What's number 2? 0.5 to 0.79. Actually, it's less than or equal to 0.8. So this is the 0.5, and this is actually 0.5 to 0.3, 0.3. Wow, I'm doing this really poorly. Okay, and then this is less than. Okay, and this is greater than or equal to, blah, 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 blah. All right. What they changed that to is the GOLD guidelines 1, 2, 3, and 4. Now, this is stuff that should be all reviewed. This is not new. This has been around since 2010, actually. This part of it has. What changed in 2014 is they added categories. They talked about, we have GOLD stage 1, but then we added categories to that, which were A, B, C, and D, right? Remember this nice thing? All right, on this, what is your x-axis?
And then let's see, order severity, right? Like exacerbations and
No.
COPD on the other axis.
When X is.
This whole thing's COPD. This is X. What are we talking about with X? Symptoms. Okay, so then we talk about Y. What was Y? Yes. Basically, where they fell here, right? So in general, you kind of had 1 and 2, 3 and 4 mixed for stage with symptoms. So it made sense, right? If they were mild disease, they didn't have a lot of symptoms, they fell into this A, this B, this C, this D. And the beautiful thing about this, the reason why they did this is because we started to have more and more reasons to treat them or more and more ways to treat them. And so the idea was, okay, when do we engage these different classes of medications? Now, I would love to give you another lecture on the different devices and different medications that are in for COPD. We're not going to have time to go through that. But A, essentially, you're dealing with somebody who's got just their symptoms are very infrequent. And so these are people that are going to get by with short-acting medications. But remember, short-acting medications are rarely indicated in chronic diseases. Doesn't matter what class of medication you're in. If they've got chronic disease, think about long-acting meds, okay? Because it's not going away. After A, B, C, D, indications become for long-acting medications, and we need to be making those transitions. Now, this is all fine and dandy, but some of you may or may not know this, but there's another category right over here. Does anyone know what that one was? This is 2014 update. What was this other category? Exacerbations. So it didn't matter what stage was or severity was if exacerbations were happening, okay? And really I would say this is really what we're looking at, severity. If they were having a lot of exacerbations, they could have no symptoms, but they kept coming in and needing, well, what's the definition of an exacerbation? An increase in symptoms from their baseline, right? And actually they looked at it, the first initial look at exacerbations, they were looking at hospitalizations. They were saying if you needed to be hospitalized for treatment. Well, they've gotten past that. They've said, no, if you need treatment outside of your normal therapeutic, that's considered an exacerbation. If you have to increase their steroids, if you have to give them steroids, you have to give them antibiotics, that's considered an exacerbation, okay? Does anybody know what the two were right here and right here? How many exacerbations were you allowed? 0 to 1. 0 to 1. This is greater than 1. But that 1 had a caveat. If it could be managed outpatient, if it required hospitalization, you were immediately sent up here. Okay? That was 2014. The update in 2017 basically said this. We're going to leave this much alone. But we're getting a little bit concerned that exacerbations are being ignored. Exacerbations are really important when we start talking about rehospitalization, when we start talking about managing and how well are we taking into consideration this increased frequency of interaction with the patient. We talk about how stable is this patient from a treatment standpoint. We were getting out of the habit of looking at exacerbations and we were just looking at how severe. So they got rid of this. Now, your X and Y axis are symptoms and exacerbations. They left the definitions the same. Now, instead of saying you are a COPD category A disease, what that used to tell you was you were a person who you had COPD, you had defined COPD, you had not a lot of symptoms, and you had mild, maybe some moderate disease, okay? Now, we say you are COPD, stage, or actually it's, sorry, class 1, category A. So there's class 1 tells you severity, and this tells you their risk of exacerbations with symptoms. So suddenly now when we're talking to patients who have COPD in the outpatient, this exacerbation question becomes a lot more pertinent. when we're wanting to get the best definition and the best diagnosis we can for them in a room of, ICD, whatever it is now, 10. This is what we need to do. This is what you should be gearing towards. Is it possible to have COPD class 1 category C disease? Yeah, it is. If they have exacerbations, if they've been in the hospital in the last year, technically they fall into that class. And the whole point of this is to give us a better indication of how aggressive we need to be with therapy for them. Mild, moderate, severe, very severe doesn't mean anything. This tells us how we should treat them. Remember at the beginning of this, I said, for me, a disease name should really tell you what to do for a person. We talked about chronic bronchitis. Does chronic bronchitis tell you what to do for a person? No. Does emphysema tell you what you need to do for a person? No. If you see somebody who's COPD class 3 category C disease, does that tell you how you might want to treat the person? Absolutely. And that's what we are hearing. And this is what, when we talk to other doctors, we want to be able to tell them why we're doing what we're doing. When we talk to patients, this is what we do to give them the information that we give them. Okay? I hope that was a good review for you. Going through all this and understanding how this changes over time is important with these patients, especially when we're talking to them in the outpatient arena, but also understanding the importance of readmission and how that changes the inpatient management as well. Any questions? Yes?
Yeah, I was just wondering, that statistic that you gave about the age of 45 kind of being the cutoff on people stop smoking, where did you find that statistic?
That is an old statistic that came out of, where did that come out? It was from the American Thoracic Society, but it probably came out when I was a resident. And it's just one that's kind of stuck with me. And it's purely an epidemiological thing. There's going to be different people for everything. But in general, if you can tell somebody to quit smoking by 45, and it really doesn't matter what their PACURE history was prior to that, does, but it doesn't. They can actually go most of their life without having symptoms. Any other questions? Yeah.
Yeah, I'm sorry, I just had one other question. So since this is something that you deal with a lot in your outpatient basis, at what point have you noticed that the majority of your newly diagnosed or patients who will be newly diagnosed with COPD, at what point are they first presenting to you in this disease process?
Most of the time, people who are presenting to me are pretty far along, okay, because they're older and they haven't been diagnosed, or they've been, actually, most of the people who come to see me have already been diagnosed, okay, and their disease has progressed to a point where whoever is their primary care provider doesn't feel comfortable with it, or the patient doesn't feel like they're getting where they wanted to get, and they wanted to come see somebody else to ask them their opinion. That's where a majority of mine come from. Now, there are a lot of patients out there who get treated multiple different times with pneumonias and various different things. They'll get antibiotic after antibiotic after antibiotic, and nobody's ever checked. Or they have a diagnosis of COPD and no one's ever checked. They just have it. Because remember, before there were really strict guidelines for what defines it, you could basically make it based upon just history, but that's not true anymore. Yeah.
Yeah, I was going to point out less than 20% of patients that are on more than 2 medications for COPD have ever had a pulmonary function test.
Yeah, that's a major problem.
Yeah.
We actually check, if somebody comes to me and they have COPD and they can't tell me when their last pulmonary function test, every single one of them gets a pulmonary function test. And they also get checked for alpha-1 because it's free. So.
How often do you repeat?
How often do I repeat PFTs? If there's a significant change in symptomology, or if we're making, like if we're looking to maybe change therapies, that's really the only reason. I won't necessarily do a full pulmonary function test on somebody. I may do spirometry on them once a year or whatever, just to kind of see how things are progressing. I think doing repeat studies is much more common in asthma than it is in COPD. Because we're not expecting big changes over time, right? We're not expecting recovery. In asthma, you're looking for recovery. You're looking for improvement. Any other questions?
Do the repeat studies in COPD potentially have value if you suspect that, yeah, you're a smoker, you're not a big smoker, but I feel like in Kirksville, we have a lot of the 5%ers who were never smoked a day in my life and developed COPD, and they're exposed to farm dust or other occupations. Is that helpful, do you think, to at least do an initial yearly repeat and make sure that if they've stopped smoking, that they're still not progressing?
Because of other reasons?
Yeah.
Do you have a thought?
Yeah, so the latest version of the gold guidelines actually talks about this, and there's a sweet chart, well, it's a graph, shows the rate of decline of FEV1 in different phenotypes. And that's kind of an evolving thought in COPD. Getting old guidelines are great, but they're industry sponsored. Gold is funded entirely by Behringer Ingelheim. Take that, do with it what you will. but you got to find some way to phenotype these people as to how they actually perform clinically. Is this somebody that's going to have frequent exacerbations? Is this someone who's going to, a little lady who technically meets criteria but has never smoked and just has the exact same lung function for a decade, you know? Or is this somebody that is going to have rapid decline in function, independent of, or go on to develop bronchiectasis? Trying to find a way to break these people down into groups and better stratify them. And now, back in days of war, before 2010, I remember having an argument with Dr. Anderson in 2009 about the utility of follow-up pulmonary function tests. At the time, gold wasn't the thing yet, and you actually had to show to make it chronic obstructive pulmonary disease, you actually had to show a decline in FEV1 over a period of time. And so we were checking annual PFTs on everybody and repeating them forever. And some people did decline a lot faster than others. I have, and no one else does either. I don't know how to predict ahead of time who's going to be in that category.
But that's where a lot of studies are right now. I mean, from a genetic standpoint, and then also looking at bronchoalveolar lavage in some of these people and looking for certain cellular markers. People who have increased levels of eosinophils in their bronchial washings are at increased risk of exacerbations. That's where some medications like Dalaresp, you've heard of Dalaresp, the pill, that stabilizes those cells. It specifically stabilizes neutrophils, but it also stabilizes the eosinophils. And the thought is that that's probably why it decreases overall exacerbations for those individuals. But it really only does it for individuals that have elevations and have risk of degranulation. But how do we figure out who those people are, right? So there's a lot of studies, and then you can talk about the different models. You can talk about the Dutch model of disease progression. You can talk about the protease, basically the alpha-1 category. You can talk about the English model for disease progressions that looks at, where did this originate? How has this changed over time? And as far as to understand full pathophysiology that's going on. The whole point of this is to give you the ability to direct your therapy a little bit better based upon more data. It doesn't just matter what their severity is. It doesn't just matter what their symptoms are. It doesn't just matter their exacerbations. We need to take all of that into consideration when we're making a choice for treatment. And really what this did overall is it made us treat more aggressively, more quickly. Because that's really what we needed to get to. People are undertreated for COPD. And so we need to be more aggressive. Any other questions? Thank you, guys. We'll chat with you later.